Your blood pressure is controlled. Your doctor at every checkup seems genuinely satisfied. The lisinopril is doing its job, and that is exactly what makes what I'm about to tell you so important and so easy to miss until it's too late to reverse. Because the truth about lisinopril and the kidneys is not a simple story. It is not, this medication is dangerous, and it is not, this medication is completely safe. It is something more complicated, more specific, and far more important than either of those headlines. It is a story about the difference between protection and damage, and about how thin that line can be inside a body over 60 that nobody is watching carefully enough. I'm Dr. Eleanor Bennett. Subscribe to this channel before we go any further, because what I cover here is the kind of guidance that should be delivered the moment a lisinopril prescription is written. It almost never is. Today it is. Let me start with the question at the center of this video. Can a medication prescribed to protect the kidneys also damage them? The answer is yes, and understanding how both things are true at the same time is the most important thing any senior on lisinopril can know. Let me start with Helen, because Helen's story begins exactly the way most kidney stories on lisinopril begin. Not with a crisis, not with obvious symptoms, but with a number on a lab report that nobody explained properly. Helen was 72, had been on lisinopril for 3 years, and had always been told her kidneys were fine. Her creatinine, the kidney function marker most commonly checked, had been normal at the start of treatment and remained within the acceptable range at every subsequent test. She felt well. She had no symptoms that pointed toward her kidneys. And then, at a routine checkup with a new doctor covering for her regular physician, someone looked at the trend rather than just the most recent number. The creatinine had been slowly climbing for 18 months, not outside the normal range, but moving, consistently, in one direction. That trend told a story that a single number had been hiding, and that story required immediate attention. Helen had not been warned that this could happen. She had not been told that lisinopril's effect on the kidneys requires watching not just the current value but the direction it is moving over time. She had assumed that normal meant safe. It had not occurred to her that a number could be technically normal and still be telling a dangerous story. Nobody had told her otherwise. Here is the fundamental truth about lisinopril and the kidneys that every senior on this medication deserves to understand clearly. Lisinopril is an ACE inhibitor. It works by blocking an enzyme that produces a hormone called angiotensin II, a powerful constrictor of blood vessels. Block that hormone and vessels relax. Blood pressure falls. That is the intended effect throughout the body, but inside the kidney, the story is more specific. The kidney has its own pressure-regulating system. Its microscopic filtering units, structures called glomeruli, receive blood through one vessel and release filtered blood through another. Angiotensin II, the hormone lisinopril blocks, causes the outflow vessel to constrict. That constriction maintains the pressure inside the glomerulus that drives filtration. Block angiotensin II, and that outflow vessel relaxes. Filtration pressure drops, and the kidney filters at lower internal pressure. In a patient with diabetic kidney disease or hypertensive kidney damage, that pressure reduction is protective. It reduces the mechanical stress on already damaged filtering structures. It slows the progression of kidney disease. In the right patient, at the right dose, lisinopril is genuinely one of the most kidney protective medications available. This is not in dispute. But in a patient whose kidneys are already relying on elevated internal pressure to maintain adequate filtration, particularly in the context of age-related changes, narrowed renal arteries, or any condition that reduces blood flow to the kidneys, that same pressure reduction becomes a problem. Reduce the filtration pressure in a kidney that needs it to function, and filtration efficiency drops. Waste products accumulate, creatinine rises, and the medication that was supposed to protect becomes, in that specific context, a source of the very damage it was prescribed to prevent. This is not a rare scenario. It is a predictable one, and it is why lisinopril requires monitoring that goes well beyond checking whether the number is inside the normal range. Norman was 69 and had been on lisinopril for 18 months when his doctor ordered a routine blood panel. His creatinine came back at 1.3 DAR, slightly above the upper limit of normal for his age and size, but not dramatically. His doctor noted it, compared it to the previous value of 0.9 taken before starting lisinopril, and recognized immediately that a rise of that magnitude after starting an ACE inhibitor required urgent evaluation. Was this a sign that lisinopril was damaging Norman's kidneys? Or was it the expected, acceptable hemodynamic response to a medication that was otherwise working well? That distinction matters enormously. A small, stable rise in creatinine after starting lisinopril, sometimes up to 30% Thi, can be an expected consequence of the medication's mechanism and does not necessarily mean kidney damage is occurring. But a rise that continues beyond that threshold, or that does not stabilize, or that occurs in a patient with risk factors for impaired renal blood flow, is a warning that demands a response. The difference between those two scenarios cannot be determined by looking at a single number. It requires knowing the baseline, understanding the trend, and evaluating the full clinical picture. Norman's situation turned out to be the latter. He had undiagnosed narrowing of one of his renal arteries, a condition called renal artery stenosis, that had been asymptomatic and undetected. In his case, the kidneys had been compensating for reduced blood flow by maintaining elevated internal filtration pressure. Lisinopril removed that compensation. His creatinine rose not because the medication had introduced a new problem, but because it had revealed one that already existed. The medication was not wrong, but the full picture had never been properly assembled, and until it was, nobody could make the right decision about his treatment. Now let me talk about the combination that turns lisinopril from a protector into something else entirely, because this is where the most preventable kidney damage in senior health occurs. Not from lisinopril alone, but from lisinopril combined with something that millions of seniors use without a second thought. NSAID's ibuprofen, naproxen, the medications people take for arthritis, for back pain, for the knee that has been problematic for years, for the headache that comes with a long afternoon. Over the counter, accessible, familiar, assumed to be harmless because they are sold without a prescription. In the context of lisinopril, they are not harmless. Here is why. The kidney maintains its blood flow through a careful balance of two mechanisms, one that dilates the incoming vessel and one that constricts the outgoing vessel. Lisinopril relaxes the outgoing vessel, reducing filtration pressure. NSAIDs constrict the incoming vessel, reducing the blood volume entering the kidney in the first place. Together, they attack both ends of the kidney's pressure equation simultaneously. Incoming blood flow is reduced. Outgoing pressure is reduced. The kidney is caught between two forces both pushing in the same direction: less perfusion, less filtration, more strain. Add dehydration to that picture, which is common in hot weather, during illness, or simply in an older adult who is not drinking enough, and the combination becomes genuinely dangerous. Not eventually. That day. Miriam was 71, on lisinopril for blood pressure, and used ibuprofen 3 or 4 times a week for her hip arthritis. She had been managing this combination for 2 years without obvious consequence. Then came a summer week of unusual heat. She did not drink as much as usual. Her appetite was reduced. She took her lisinopril faithfully and her ibuprofen as needed for the hip. By day 4, she felt profoundly weak. By day 5, she was nauseated and barely urinating. Her daughter drove her to the emergency room. Her creatinine was dangerously elevated. She had developed acute kidney injury, sudden, severe, and requiring immediate intervention. She recovered, but her kidney function never fully returned to where it had been before that week. Miriam had not been careless. She had simply never been told that the combination she was managing successfully in normal conditions would become dangerous under the specific conditions of that summer week. Nobody had connected those dots for her. And nobody had explained that dehydration is not just uncomfortable. In the context of lisinopril and regular NSAID use, it is the catalyst that can turn a manageable combination into a medical emergency. This is why the over-the-counter pain reliever conversation must happen every time lisinopril is prescribed. Not once. Every time. Because the patient taking lisinopril in January is not the same patient taking it in August during a heat wave with chronic arthritis pain and reduced fluid intake. The risks change with the seasons, with the circumstances, with the body. The conversation needs to keep up. Now let me tell you what proper monitoring of lisinopril in the kidneys should actually look like. Because what most seniors receive and what they actually need are often not the same thing. At the start of lisinopril treatment, a baseline creatinine, eGFR, and potassium should be established. Not just checked, documented clearly as the reference point against which all future values will be compared. Within the first 1 to 2 weeks of starting, or after any dose increase, those values should be rechecked. Not because something is likely to have gone wrong, because that window is when acute hemodynamic changes are most likely to appear, and catching them early is the difference between a dose adjustment and a hospital admission. Ongoing monitoring, every 3 to 6 months in stable patients, more frequently in anyone with pre-existing kidney disease, diabetes, heart failure, or regular NSAID use, should look at trends, not just current values. A creatinine of 1.1 that has been 1.1 for 3 years tells a completely different story than a creatinine of 1.1 that was 0.86 months ago. The number is identical. The stories are not. Potassium must also be monitored as part of any lisinopril follow-up. The same mechanism that makes lisinopril kidney protective, blocking angiotensin II, also reduces the kidney's ability to excrete potassium. Potassium can accumulate quietly, without symptoms, until levels reach a range that affects the heart's electrical system. In seniors who are also eating potassium-rich diets, using salt substitutes, or taking other medications that affect potassium, that accumulation can happen faster than anyone anticipates. And the conversation about what else is entering the body alongside lisinopril, OTC pain relievers, supplements, salt substitutes, dietary changes, must be part of every significant checkup, not an afterthought, a deliberate, systematic review of the full environment in which the medication is operating. Let me be specific about the potassium story, because it is the part of lisinopril monitoring that is most consistently underestimated and most quietly dangerous when ignored. Gerald was 74, on lisinopril for 4 years, and felt well in every respect. He had made admirable lifestyle changes: more fresh produce, less processed food, a daily walk, reduced sodium intake achieved through a potassium-based salt substitute. His blood pressure was well controlled, his doctor was pleased, his potassium had been checked once at the start of treatment and had been normal. In the 4 years since, it had not been rechecked. During that time, the combination of lisinopril's effect on potassium excretion, his increasing consumption of potassium-rich vegetables and fruits, and his daily use of a potassium-based salt substitute had been steadily pushing his potassium upward. Nobody was watching. Nobody had thought to look, because nobody had assembled the full picture. Gerald came to clinic not because of a dramatic event, but because his wife had noticed his energy had dropped significantly over the past few months and had insisted he be seen. His potassium, when finally checked, was dangerously elevated. His EKG showed changes that required immediate management. He had been, without knowing it, accumulating a cardiac risk in the background of a medication routine that looked perfect on the surface. The kidney story and the potassium story are inseparable in lisinopril monitoring. They are both part of the same mechanism, the same medication effect, the same monitoring requirement, and they both reward the same behavior in patients: asking, reporting, and refusing to assume that feeling well means everything is well. Let me bring you back to Helen. When her new doctor identified the creatinine trend, a full picture was assembled for the first time. Her diet had changed: more whole foods, more potassium-rich vegetables. She had started using a salt substitute. She took ibuprofen occasionally for knee stiffness. None of these had been reviewed in the context of her lisinopril. All of them were contributing to a kidney environment that was under more strain than anyone had realized. Changes were made. The trend stabilized. Her kidney function did not recover lost ground, but it stopped losing more. She told me afterward, "I thought the blood test results were just numbers my doctor was keeping track of. I didn't know I could read them. I didn't know there was a direction in those numbers that mattered as much as the number itself." That sentence is the reason this video exists. You can read the direction, you can ask your doctor to show you the trend, not just the current value. You can ask specifically whether your creatinine has been moving and in which direction over the past year or two. You can report every other substance you are taking, every supplement, every pain reliever, every dietary change, and ask whether it belongs in the picture alongside your lisinopril. You are not required to understand the mechanism fully. You are required only to ask the right questions. And the most important question at your very next appointment is this: looking at my kidney function over the entire time I have been on lisinopril, not just today's number E, what is the trend, and is it telling us anything we need to act on? That question is not complicated. It does not require a medical degree. And it may be the most valuable question you have ever asked at a checkup. Your lisinopril may be protecting your kidneys beautifully. For many seniors, it is doing exactly that. But protection and damage can come from the same medication, in the same body, depending on factors that are absolutely worth understanding and monitoring. The number alone is not enough. The trend, the context, the full picture, that is where the truth lives. Share this video with someone who takes lisinopril and has never seen the trend in their kidney numbers. Subscribe to this channel, and I will see you in the next video.